Well, I've got 7 o'clock and we got about 30 people. I'm sure more will jump on shortly. Jonathan Corren is a hard guy to pin down. We had to move his talk a couple of times, but I'm very happy he's here with us this morning. Probably a little warmer in LA than it is down here at the beginning of today. But that notwithstanding, type 2 low asthma from antibiotics to biologics. Looks like a very valuable talk, Jonathan. Thanks for doing this and getting it all pulled together. So go ahead and start whenever.
Okay, thank you, Len. And it's always a pleasure to whether it's coming up to Seattle or doing this on Zoom. I enjoy lecturing to your group and trying to understand some things that have been sort of difficult to understand. And today, we see so much low type 2 asthma. I thought this would be a very relevant and timely talk, especially during this particular time where we're trying to develop specific therapies for this group. As disclosures, I've worked with a number of companies, both doing research as well as lecturing and consulting, which are shown here. And as an overview, we're going to start with trying to piece together some kind of a definition for what is low type 2 asthma. What are some of the hallmarks of diagnosis as we stand here today? Move on to some of the key points of pathogenesis and what can be employed as biomarkers, if any, and then talk about both current and future therapies. So let's talk a bit about definition and diagnosis. And if we think back, it's not that long ago that we just talked about asthma. We really didn't have the terminology of Th2 or type 2 until really a very small number of years ago, when we began to realize the critical nature of coming up with both clinical and molecular phenotypes for patients with asthma. So what's the definition of type 2 low asthma? Well, let's first assume that there's a definition of asthma, and it really is contingent upon classic symptoms, sometimes not so classic, combined with physiology. And some of the things that differentiate low type 2 asthma in terms of symptoms are, at least in the sort of crudely put together analyses of the clinical profiles of these patients, there seems to be an increase in cough, including productive cough, and an increase in infections. So in that way, it may be distinguished in not all, but some patients who have low type 2 asthma from type 2 asthma. The physiology is, at least in clinical trial work, is required to meet the same physiologic definition as regular asthma or high type 2 asthma, which is reversibility of greater than 12%, the 200 cc increase in FEV1 after inhaled bronchodilator. I think what we're going to be seeing is some modification of these requirements, particularly with regard to low type 2 asthma, because lung function may be lower, and along with that, there may be incomplete reversibility. Certainly, bronchial hyperresponsiveness is a required element. And I think this is where, as we begin to question some of these predicates upon which we've always based our definitions of asthma, and understanding the spectrum of airway disease as we go from asthma to COPD to bronchiectasis, I think we're going to be seeing some of these lines actually blurring over the next few years. And then we're going to be emphasizing not as much these stringent definitions of these various subsets of obstructive airways disease, but we're going to be paying more attention to treatable traits, which has become a very popular term, both within the respiratory field as well as other specialties of medicine. So if we take a group of people that have so-called type 2 high and compare them with type 2 low asthma, we end up with some broad generalizations, which can be made for the groups. I think we're waiting to see a really good publication in this regard. But what I can gather from the published literature, as well as my own experience, is that the age of onset is often different. Type 2 low tends to occur later. Symptoms and exacerbations. Symptoms tend to be more severe and exacerbations fewer when you compare these patients that have type 2 high asthma. So the burden of disease on a daily basis may outnumber or overwhelm these so-called sporadic rare events known as exacerbations. airway infections are quite frequent in this group of people, which I think really gets at some of the underlying pathophysiology, versus people with type 2 certainly have them, but they're not part and parcel of the disease. Frequently, these people have a smoking history, occasionally in type 2 high. Response to corticosteroids is notoriously poor in this group of people. They don't have the so-called machinery that corticosteroids work upon. And in people with type 2 high, it's usually fairly good, although certainly we see steroid resistance in this group of people as the disease becomes more severe. Sputum eosinophils, one of the key underpinnings of type 2 disease, is notoriously absent. Sputum PMNs may be present, but they may also be present in type 2 high asthma, particularly in more severe patients where you get a mixed inflammatory infiltrate. And then finally, exhale nitric oxide typically is normal while it's elevated in type 2 high. So when we look at this list, at least with regard to these bottom three biomarkers, it's much more about what type 2 asthma isn't as opposed to what it is. And this really bespeaks of a loud need in research to help really refine and hone these various subset of what low type 2 disease really is. So a wonderful publication recently done by Guy Broussel with Hinks's first author, just came out a couple of months ago in the European Respiratory Journal, advocates doing the typical biomarkers, blood eosinophils, sputum cell differential, and exhale nitric oxide. Notoriously missing from this list is periostin, which has pretty much been shown at this point not to correlate or be predictive of responses to therapy. If you have patients who have eosinophils greater than 150, FeNO greater than 25, or sputum eosinophils greater than 2%, although some advocate even as low as 1%, you've got type 2 high asthma. But if you're less than 150, less than 25, and sputum eosinophils of less than 2 or 1%, you have type 2 low asthma. Interestingly, you have to combine these three. Not one of these alone makes the diagnosis of non-type 2. Certainly, if we go down to the diamond, we need more biomarkers. And some people have advocated using myeloperoxidase as a potential marker. This is in development. If you don't have these biomarkers, then you've got polygranulocytic asthma. If any one of these things is present, or if all these things are present, and you've got sputum neutrophils, then you've got neutrophilic asthma. And where you see a lot of neutrophils is in occupational exposures with smoking, mycobacteria and fungi, and the list goes on. And a key part of establishing neutrophilic asthma, and we're going to get into this more in a moment, is that you have to consider aggravators, which is shown in the box at the bottom. And this is where airway infections, I think, really becomes paramount, that we don't assume that this is, quote, asthma, and that there's not some underlying predilection caused by chronic colonization and potentially infection of the airway. And this includes non-tuberculous mycobacteria. Some of the systemic diseases for which we see in this situation are cystic fibrosis and primary ciliary dyskinesia. I think it's very important in this group of people with persistent neutrophilia to evaluate the possibility of bronchiectasis. And if it doesn't show up on a chest x-ray, as it often doesn't, to get a high resolution CT. A plain CT, of course, wouldn't pick it up. Considering the possibility of immune deficiency. And then you get into that very gray territory where do you have non-type 2 asthma with neutrophils, or do you have COPD? And certainly a smoking history of more than 5-pack years would point us more in the direction of COPD, particularly if the CT shows us evidence of emphysema in the lung. So if we explore the pathogenesis and try to contrast this with what we've learned about type 2 asthma and dig into some of the potential biomarkers. As I mentioned, from the flowchart, we have neutrophilic as one possibility, and we have polygranulocytic, which should be the absence of neutrophils. A number of different boundaries has been established as defining neutrophilic asthma. And it's defined not as a number of cells, but typically as a percentage of white cells. 61% has landed as becoming the most popular cutoff. Some have used 64%, some have used 50%, but typically it's in the 60s. And this just, I think, speaks to the need for more definitive research. if you take a group of patients who have low type 2 asthma, in the neighborhood of 22% of patients will have sputum neutrophils. And as I mentioned earlier, and to emphasize this again, we find this to a greater extent in people who are smokers, who have been exposed to air pollution, in patients with obesity, certain occupational exposures, airway infections, bronchiectasis, and interestingly, fungal exposure. And in one area where we've certainly seen this is both animal models and in humans with ABPA, where you can detect neutrophils in the airway, potentially as a result of Th17 cell activation. So prostagranulacidic is again implying the rule of what isn't rather than what is. It's defined as PMN of less than 61%, sputum EOs of less than 2%, and a normal exhale nitric oxide. It's thought that overall, in the overall population, up to 48% of asthmatics in some series have had prostagranulacidic. In patients with non-type 2 asthma, it's difficult to say, but certainly a big chunk of these patients are thought to be prostagranulacidic. If a person is identified as having an absence of inflammation, whether it be eosinophilic or non-eosinophilic, 22% have been identified as having severe refractory asthma. And this has been a particularly difficult group to treat with inhaled corticosteroids, as well as biologic medications. Now, one thing to keep in mind is that some patients will not demonstrate eosinophils on both sputum samples or bronchial washings, but will have positive staining for eosinophil granular proteins, things like EDN or ECP, in the absence of intact eosinophils. And this, I think, again, is going to start to force us in this group of patients who have non-type 2 asthma to really look at sputum as a necessary requirement to making both an accurate diagnosis and an accurate an accurate assignment of therapy that might be effective. So if we look at some of the cells and cytokines involved in low type 2 asthma, well, we know that we've got irritants, pollutants, bacteria and viruses, which have landed on the epithelium and stimulate the epithelium. We know about the alarmins, TSLP, IL33, IL25, along with that IL6 and IL23 seem to be released by the epithelium as well. And along with this, the epithelium also has the ability to be one of the sources of interleukin 6, GM-CSF, and interleukin 8. And if you look at this list of cytokines that are first released upon contact of the epithelium with some of these triggers, we can see that some of them are very relevant to type 2 asthma as well, particularly TSLP and IL33. You end up with activation of Th17 cells. And some of this is based on experimental evidence, but a lot is based on speculation. These IL17 cells, or Th17 cells, can then release IL17A, IL17E, also known as IL25, and IL8, which is a very prominent chemoattractant for neutrophils. By the same token, on the other side, Th1 cells can be stimulated, particularly by IL33, which gives rise to the very important Th1 cytokines, interferon gamma and TNF alpha, again, which bring in and activate neutrophils. So this is a plausible chain of events. There's experimental evidence to certainly support the presence of many of these cytokines in BAL fluid. What's missing really is the detection of these in a milieu where we're really looking at specifically low type 2 asthma, and more work needs to be done in that regard. But if we flesh this out a little bit more, and we focus on Th1 cells and the macrophage, we can see that the macrophage on the right, with regard to the inflammasome NLRP3, with contact with viruses particularly, releases IL1 Beta. It's a very important chain of events that then stimulates the epithelium to release not only the cytokines that we just talked about, the alarmins, but a number of very important chemokines that specifically focus on the neutrophil. These include CXCL1, 2, 5, and 8, and CXCL8 is IL8. These bind to a variety of different receptors, the best characterized of which is CXCR2, and you get attraction of neutrophils into the site of inflammation. If we flip to the Th1 cell in the middle, which would have required some kind of activation upstream from this event. We know that we get release of both TNF alpha, which has direct effects on both bringing in neutrophils, activating neutrophils, and causing direct cell damage. And we also get interferon gamma, which stimulates the macrophage to release chemokines, particularly CXCL10, which again binds to, brings in, and activates neutrophils. And you can see a lot of other modifying factors scattered around this. But if we really sort of focus on the macrophage, Th1 cell, and neutrophil, I think we are starting to get an evolving idea of what constitutes so-called low Th2 asthma. So if we look at some of the clinical data, and I drew this from a number of sources, if you look at the prevalence of normal sputum eosinophil counts in various groups, in mild to moderate patients, you'll have 75% of the time there will be a normal sputum eosinophil count. Interesting. And this may be because of the mildness of the disease. You're not getting eosinophils ingressing into the sputum. But if you were to have done BAL, or potentially even better than that, a mucosal biopsy, it may have been higher. If you look at untreated symptomatic asthmatics, and this is all comers, not just severe and not just type 1 versus type 2, you get about 25% actually have a normal sputum eosinophil count, which would then define low type 2 asthma as about 25% of that population. If you then shift it and bias the sample by looking at severe patients who are taking high dose ICS, potentially because of the effects of the ICS on the eosinophilic component, the number of normal sputum eosinophil counts drops to about 50% of patients. So we can say from this that somewhere between 25 to 50% of patients, depending on severity level and symptom level, probably have low type 2 asthma. And if we look at the consistency in a publication done a couple of years ago by Van Veen, published in the Journal of Allergy, they took 50 patients and wanted to see over a year's time if you had a sputum phenotype of either eosinophilic or non-eosinophilic, what percentage of the time would you stay in that phenotype? So if you stay within the gray box, and these two axes, the Y and the X, define the first and the second attempt to get sputum, we can see that of that 50 patient group, about 14 of them, or roughly 30%, ended up having consistent sputum eosinophilia. 20 of them, roughly 40%, ended up having, in the lower gray box at the bottom, consistently non-eosinophilic sputum. And only about 5, or roughly 10% of the patients, had left their grouping and went either into the high eosinophil or low eosinophil group. And I think data like this helps us flesh out the fact that there is a sort of a dynamic shift. And sometimes using these very crisp cutoffs of eosinophils and exhaled nitric oxide can be misleading and really misclassify a patient. I've been involved with a couple of publications looking both specifically at high type 2 patients as well as asthmatics in general. What we find is that patients who are less than 150 eosinophils will more often than not stay in that group. Patients who are greater than 300 with eosinophils will tend to stay in that eosinophilic group, as we can see from the sputum data. But people in the gray zone of blood eosinophils between 150 and 300 may go into the lower group or into the higher group much more often than patients at the two extremes. So again, to reinforce that, there is a dynamic flux of patients across these boundaries of biomarkers, and we have to keep that in mind when trying to make a classification about what biologic to pick. Well, we talked about infection. What about the role of bacteria? Certainly we know in patients with low type 2 asthma, the most prominent colonizers are Moraxella catarrhalis and Haemophilus influenza. But along with this, in these patients, there tends to be a reduction in microbial diversity, owing in part to the frequent use of antibiotics in this group of patients. What we end up with at the end of the day is a chronic activation of the epithelium and chronic activation and maturation of both Th1 and Th17 cells, which are allergens or antigen specific for the bacteria we've talked about. So now we're going to explore both current and future therapies and try to understand really what is the lay of the land of this. And when we look at treatment options for type 2 low asthma, we've got macrolides, small molecule antagonists, monoclonal antibodies, bronchial thermoplasty, and treatment of obesity. And I think all of these things will end up playing important roles as we move forward. But what we're really going to talk about today are the macrolides, the small molecule inhibitors of certain selected pathways, and monoclonal antibodies. And originally this talk was entitled Biologics, and I thought we'll talk about biologics, I think, in this regard, where we seem to know much less than we do about type 2 biologics. And by the way, I think bronchial thermoplasty and treatment of obesity really constitute lectures unto themselves, because there is a growing body of literature to support these two modalities, particularly treatment of obesity, which I think we oftentimes tend to assume the patient will remain obese, and we're just going to try to treat the problem with medication, whereas I think in many patients, the real treatment is to reduce BMI. So let's start with the discussion of macrolides. And before we dig into the azithromycin data, which really has become the key data, I'm going to take you back on a little tour through history. When I was at National Jewish back in the late 80s, and I worked with Richard Martin as a mentor, and he had already become very interested in the role of atypical bacteria, atypical organisms, including chlamydia pneumonia and mycoplasma pneumonia, as possible aggravators of asthma, and in some cases, really the chief inciders of inflammation, particularly neutrophilic inflammation. And in the mid-90s, after I had left, Richard Martin and Monica Kraft certainly spent a fair amount of time looking at epithelial brushings from the lower airways and defining potentially the role of macrolides as a way of treating these patients in the long term. And the macrolide that they had chosen was clarithromycin. And they found that many times you had to treat patients for 3 to 6 months. And some very interesting data came out around 2010 from Jim Good, also at National Jewish, who advocated using bronchial washings and fiber optic bronchoscopy in patients with very severe asthma. And at that time, irrespective of the peripheral phenotype, whether they were eosinophilic or not, to try to determine whether there was evidence of chronic ongoing infection, whether it be from an atypical or even a more typical bacteria, and try to help define the role of antimicrobials in these patients. So a lot's been learned since Richard Martin, I think, really started to develop this idea. And macrolides have been postulated to have a number of different mechanisms of action. Of course, they're antibacterials, and they have been shown to reduce colonization by bacteria like Haemophilus influenza. But there are also immune effects that we think are very important. This includes actual immunomodulation of lower airway inflammation with an inhibition of transcription factors. And one that's been focused on particularly has been NF-kappa B, a reduction of activation and migration of neutrophils, probably through modulation of NF-kappa B and downstream evolution of chemokines like the CXCL8. Revitalization of corticosteroid sensitivity. And many of these patients, as we've talked about, have been corticosteroid resistant. And it's thought that this can be done through inhibiting phosphatidylinositol 3 kinase and increasing histone deacetylase 2. So these two pathways may, by inhibiting them with a macrolide, may restore corticosteroid sensitivity, which is really a very interesting hypothesis. And then finally, reduction of both TNF-alpha and IL17 immune responses, as we saw above this when we were talking about pathogenesis. Something else that's been recently emphasized is prokinetic properties, that macrolides are really, particularly erythromycin, which has been used increasingly in patients with small intestinal bacterial overgrowth as a way of treating both colonization of the gut with certain bacteria, but also by promoting prokinetic activities and with a reduction in aspiration and an improvement in GERD. So there was a large trial published a couple of years ago, an international cast of investigators that looked at azithromycin in patients who had uncontrolled asthma. And this includes asthma that was both type 2 and low type 2. It was a reasonably sized study, 420 adults who are all above 18 years of age, treated with an inhaled corticosteroids and long-acting beta agonist, an ACQ-6, sort of in the moderate range, not particularly severe, and there was no requirement for exacerbations. The treatment that they picked was azithromycin, 500 milligrams 3 times per week, or a placebo for nearly a year. And the primary endpoint of the study was exacerbations. They looked at sputum inflammatory cells, and they did a very good examination of safety. And this was published in The Lancet. So if we look at exacerbations on the left, we can see that there was about a 40% reduction overall. And if we try to parse this out by various phenotypic identifiers, like non-eosinophilic asthma, we see that we're right around 35%. There was actually a better improvement in patients with eosinophilic asthma, which I think bespeaks the ability of macrolides to also, which I didn't list before, a reduction in IL-13, which may be important, or certainly is important in eosinophilic asthma. If we look at the bottom at looking cough and sputum, we can see that there was probably about a 70% reduction in exacerbations in patients who had frequent cough and sputum. And if we compare bacterial negative versus bacterial positive patients based upon cultures, we can see that it worked in both, but particularly in those who were colonized with bacteria, we got about a 60% reduction. In terms of safety, fortunately, most parameters were equivalent comparing azithromycin with placebo, with the exception of diarrhea, which affected about 30% of the population. Patients treated with the macrolide versus placebo, it's about 15%. And something of concern to me is an increase in azithromycin-resistant respiratory infections, which bordered on statistical significance in those receiving the macrolide. Now, this doesn't mean that they were resistant to all types of antibiotics, but certainly to the macrolides in general. And this is something that we would have to be concerned about. On the other hand, by reducing the need for frequent other courses of antibiotics, it may balance itself out with a reduction in beta-lactam antibiotics as well as others. We may be able to sacrifice sensitivity to the macrolide class. Now, the next group of molecules we're going to talk about are the small molecule antagonists. And we're going to start with the mast cell receptor for stem cell factor, known as KIT, and look at inhibitors of KIT as a way of treating asthma. And certainly animal models over the years have suggested that mast cells are probably most relevant to airways obstruction and airway hyperresponsiveness in terms of their effects. There's certainly also a component of influence over inflammation. And some well-done studies have demonstrated that mast cell numbers correlate with asthma severity and bronchial hyperresponsiveness. And some studies have demonstrated that serum stem cell factor does correlate with asthma severity. And all of this helps build a case that the mast cell may play an important role in asthma, even if you focus strictly upon the mast cell. And we all know that imatinib inhibits tyrosine kinase activity of KIT. And when you give it to patients, whether they have asthma or leukemia or normal patients, it reduces both bone marrow mast cell numbers and serum tryptase. And this has been shown quite well in chronic myelogenous leukemia. So about 4 years ago, published in the New England Journal of Medicine, a group of investigators looked at patients, very small study, about 30 in each group, who had severe asthma. They were treated for a period of 6 months. They focused on the role of imatinib in really treating bronchial hyperresponsiveness, figuring that that would have been the most influenced by mast cell blockade and deactivation of mast cells. And what they in fact found was that at the point in 3 months and 6 months, both groups improved with respect to bronchial hyperresponsiveness, but more so in the patients getting imatinib. And we can see on the right that there was a drop, about a 40% drop in serum tryptase. And if you look at some of the secondary endpoints like asthma symptoms, asthma control questionnaire, and exacerbations, there were actually quantitative trends, but none of them reached statistical significance. But this was, I think, enough evidence that imatinib is now being explored actively in patients with severe asthma. And we will be seeing some of that in the future. But if we move away from imatinib to another small molecule inhibitor, we're going to be looking at CXCR2, which is a cysteine X cysteine chemokine receptor 2. We know, as we discussed earlier, that interleukin 8 is a key chemokine, and it has a huge effect on the activation and chemoattraction of PMNs. And CXCR2 is the natural receptor on neutrophils for IL-8. The thought being, if you can block this receptor, you can block the ingress of neutrophils into the airway. Some of the evidence that's been accumulated over the years suggests that there's an increase in IL-8 in patients who have low type 2 asthma. And we've been able to show that an increase in sputum IL-8 actually precedes exacerbations in sputum. And there's an increase in IL-8 in the late asthmatic response to allergen. So this certainly seems to be present in both allergic in allergic as well as non-type 2 asthma. The question is, what's the significance of this effect? And I think that is really the key question. We know there are neutrophils, we know we can block them, but the question is what happens? So the way we envision CXCR2 working is you end up attracting monocytes to the lungs, which then evolve into macrophages, and this helps guide PMN chemotaxis. So there's a couple of different pathways, both using monocytes and macrophages, as well as directly binding to neutrophils that can get neutrophils into the airway. So there are a number of small molecule inhibitors. These particular molecules have consistently demonstrated a reduction in sputum neutrophils on the order of 36 to 69%. And when you look at provocative challenge, that reduction goes up higher. And there have been studies looking at lipopolysaccharide challenge in humans. When you pre-medicate with a CXCR2 inhibitor, you get close to an 80% reduction in neutrophils in both sputum and airway sampling. The best study that's been done to date, published by Paulo Byrne in Lancet Respiratory Medicine just a few years ago, did a phase 2b study where they were able to demonstrate a reduction in PMNs, not 100%, but in the order of 60 to 70%, but saw no changes in asthma exacerbations and lung function or patient-reported outcomes. So the key question becomes, is the neutrophilic infiltrative pathway so redundant that if you block one potential pathway using CXCR2 and IL-8, that may not be enough? Or is the quantitative reduction not enough? Or is the neutrophil sort of an innocent bystander in this regard, and really other factors are at play in low type 2 asthma that are much more important, which I think remains a very potential answer to this question. So let's now talk about biologic therapies, which really is the cornerstone of my talk. And if we look at the biologics in current development for type 2 low asthma, there are a number of molecules that we're looking at. TSLP, tezepelumab, recently finished and published its phase 3 study. And CSJ117, a Novartis compound, finished its 2A proof of concept where it was successful in blocking the late asthmatic response to allergen and is now in phase 2B testing. IL33, astegolimab, which is an ST2 receptor, which is the receptor for IL33, completed its phase 2B testing. And there's a possibility, but not certainty, that it will move into phase 3. IL17, a number of molecules have been looked at, including brodalumab and secukinumab. Brodalumab was tested a number of years ago and failed to show efficacy, but secukinumab is currently in dose-ranging studies. IL1 Beta is another moderately attractive target, and there is a molecule, canakinumab, which is in phase 1 testing currently. And finally, IL6, SARP, the Severe Asthma Research Program, is now being funded by the NIH to look at clazikinumab, which is an IL6 inhibitor, and they're looking at that in proof of concept. So certainly in this group of patients who are not characteristically type 2, there are a number of different avenues that are being explored. Thymic stromal lymphopoietin has certainly gotten out of the starting blocks, perhaps the earliest, and met with a fair degree of success. We know along a number of different lines of evidence that TSLP is important in asthma. We find it in BAL fluid, and the tissue of asthmatics, and importantly, concentrations of TSLP do correlate with the level of asthma severity. And it's been established as a potential pathway of relevance to both type 2 high and low asthmatics. And if we look specifically at type 2 low asthma, there's a number of different cell types. which may become activated or grow under the influence of TSLP. And these include Th17 cells, mast cells, neutrophils, and smooth muscle itself, which is one of the final common pathways for all patients with asthma. Last week, the phase 3 study was published. Andy Menzies-Gow, lead author in the New England Journal of Medicine. And what I'm showing you is the exacerbation data. Tezepelumab, 210 milligrams given monthly sub-Q versus placebo to a group of patients, adolescents and adults with asthma. And we can see that overall there was a 54% reduction in exacerbations, which doesn't sound particularly out of the ordinary. But if we break it down into less than 300 and greater than 300, which is the second category, we can see that in type 2 asthmatics with bloody eosinophilia, there was a 70% reduction in exacerbations, and people less than 300, approximately 40%. So it was a confirmation of the type 2B study that I was involved in and published a couple of years back, where we saw effects in both type 1 or high type 2 and low type 2 asthma. And if we break it down even further to less than 150, we can see that the effect on exacerbations does remain. And if we look at FeNO, both high and low, we can see that in people with low FeNO, the effect was not quite as robust. We're looking at about a 30% improvement, while people with high FeNO, again, we're looking at close to a 70% reduction in exacerbations. And then finally, at the very bottom, something very relevant to allergists, whether it's patients positive to a perennial allergen or negative, the drugs seem to I think, perform very similarly. So from this data, we have a potential new therapy, if this drug is approved sometime in the next few months, to treat low type 2 asthmatics who have frequent exacerbations. What was shown in both the study done in 2017, as well as in this study in people with low type 2 asthma, the effects on symptoms and pulmonary function is not as robust as in high type 2 asthmatics. And I think that's something that we're going to be sorting out with post hoc analyses over the months to come. Now, IL33 is we often think of IL33 and TSLP as being very similar. Certainly, there's a lot of biologic evidence showing that selected single nucleotide polymorphisms of IL33 do draw a connection between this cytokine and both susceptibility to asthma and severity of asthma. And we know that, like TSLP, IL33 comes from the epithelium. It's stimulated by a number of factors, including allergens, but also viruses and pollutants. Its natural receptor, ST2, also known as the IL1 receptor, like 1 receptor, is present on a lot of important cells relevant to both type 2 and non-type 2 asthma, including ILCs, like ILC2, T cells, eosinophils, mast cells, dendritic cells, macrophages, and the endothelium. And as I showed you earlier, we can get activation of Th1, which probably plays an important role in patients who have non-type 2 asthma. And what we may end up finding out is that people can have an allergen or antigen, not allergen, but antigen-specific response via the Th1 cell. It's obviously not allergic and not type 2. That leads to the release of cytokines and chemokines that are very critical to the development of airway disease. So if we look at astegolimab, which is the Genentech compound, anti-IL33, not to IL33 itself, but to its receptor, and we look at the overall efficacy in their phase 2B study, then we can see that depending on the dose, we're getting between 27 and 42% reduction in exacerbations. And if we look at the eosinophilic low group on the right, we can see with the top dose of drug, there was about a 50% reduction in exacerbations. So certainly I think this behooves us to have an interest in IL33 and its receptor in patients who have low type 2 asthma, potentially an effective treatment. IL17, we've talked a lot about it in terms of pathogenesis, but what does the evidence actually show us when you inhibit it with a compound? So IL17, both A and F are secreted by Th17 cells. It seems to play an important role in PM migration. We find an increase in IL17 in PAL fluid and tissue in severe asthma. And again, like many of the factors we looked at, it correlates with severity and PMN count. We can break down 17A and F, whereas A seems to mediate bronchial hyperresponsiveness. F is probably more important in mediating inflammation, particularly in patients with corticosteroid insensitive asthma. And if we look at IL17 monoclonals, there's been 2 drugs that have been looked at, Kinemab, where there have been no improvements in any asthma outcome to date, but it's still being looked at using a new formulation, Brodalumab, which dates back close to 10 years ago, in a non-stratified population, all comers with asthma. There were no improvements in any asthma outcomes. In patients with high degree of reversibility, and we can see this in the graphic to the right, and we're looking at people who had all comers at top, B would be low reversibility and C would be high reversibility. We can see that in patients who receive the top dose of drug and who are highly reversible, that there is an improvement in ACQ with a drop in the line. But in terms of exacerbations, we didn't really see a tremendous amount. And if we stratified the population, not by reversibility, but by high or low blood EOs or high or low FeNO, we didn't see a particular signal in patients who had low type 2 biomarkers. So I think the jury is still very much out on the role of anti-IL-17 as a therapy, and perhaps the role of IL-17 as a mediator of asthma. And this really starts to, I think, shake the foundations of our belief that neutrophils really are a key player in non-type 2 asthma. Interleukin-1 beta, a very key upstream cytokine, is increased in BAL fluid and sputum in patients with asthma, particularly in those who are more symptomatic. And if we look at how these various factors correlate, we can see that neutrophilic inflammation, disease severity, and resistance to steroids does correlate with IL1 beta and the NLRP3 inflammasome. So we start to get a picture that IL1 beta is involved in neutrophilia. And if we look to the right, we can see from the publication by Kim a couple of years ago, if we look at IL1 beta RNA and look at both sputum neutrophils on the upper and ACQ on the lower, we can see a pretty nice correlation that was statistically significant between IL1 beta and neutrophils and IL1 beta and a patient-reported outcome of asthma. And I think very relevantly, we've done experiments that have shown that ozone does lead to an increase in IL1 beta and neutrophils. And again, whether this is the mediator of symptoms and disease, or whether the ozone is really eliciting effects in asthma by degrading the epithelium, releasing TSLP, which might have direct effects on smooth muscle, remains to be seen. If we look at what happens when you give an anti-IL1 beta, in this case it's anakinra, an inhaled endotoxin challenge in normal patients, we can see on the left we're looking at sputum neutrophils, on the right we're looking at sputum IL6, and we're comparing baseline placebo treatment and anakinra treatment, and we can see that we get a robust increase in neutrophils and IL6 in patients who are treated with placebo compared with anakinra, where this is quelled, not completely, but to some extent. So I think, again, a piece of the puzzle, I think, is important, but it remains to be seen whether an anti-IL1 beta monoclonal will really have effects. And this is something that's going to be sorted out with a different IL1 beta inhibitor over the months to come. We hear a lot about IL6 now. IL6 certainly, I think, is a great candidate molecule. We just don't know how important it is and how much of the inflammation that we see in non-type 2 asthma can be attributed to this. Certainly, we can say it's a systemic marker of inflammation. It's very easily measured in the bloodstream of patients with a number of different syndromes, particularly patients with obesity and those with metabolic dysfunction. And we also know that it's increased in the serum and airways of patients with severe asthma. Particularly in the setting of metabolic dysfunction, and the 3 concomitant conditions that have been cited are obesity, hypertension, and diabetes. Something else that's interesting, I think, is that in patients with high IL-6, we see consistently low cytotoxic CD8 cells, not only in the blood, but in the airways of these patients. And it may reflect an impairment of antiviral response in these patients and explain why they have more exacerbations and more infections. So there was an interesting little case report using tocilizumab, which is one of the anti-IL6 molecules, in 2 children with severe asthma who had a mixture of both Th2 and Th17 inflammation with eosinophils and neutrophils. And it was useful in those. So this, along with all the basic science we know, has prompted some clinical trials in patients with severe asthma. Another thing you're going to be hearing about, and I want to end with this on IL6, is that in patients who have specifically type 2 low asthma, we know that the IL6 present can bind to soluble IL6 receptors that have been shed from the epithelium. This combination of the cytokine with its receptor in the soluble phase leads to something called transsignaling on the epithelium. So this so-called cytokine receptor complex goes back to the epithelium, where it has been shown to have a very powerful effect on epithelial integrity and an effect on inducing IL33 release. So we've got another piece of the story that's being worked out, and you'll be, I think, hearing more about this in the future. But at this point, I can't report back to you any data on the anti-IL6 approach. And if we take all of this, discussion of epidemiology, of pathogenesis, and ultimately of trials of therapies that have focused on what we think characterizes the low type 2 group of patients, what we can say is, first, type 2 low asthma is a very heterogeneous group of patients that involves a lot of different comorbidities, particularly obesity with metabolic syndrome and infection. And in fact, that maybe in the future we'll think less about anti-neutrophil biologic approaches and more of a focus on investigating and uncovering infection in these patients. And I think this is why, perhaps, if we look back over all the data we reviewed today, that to me still the most promising approach, despite its side effects in most patients, may be very well azithromycin, although I'm not absolutely pleased to have to be giving chronic antibiotic therapy. And I think what a lot of this data really highlights for us is that when we try to suppress airway neutrophilia using a variety of approaches, whether it's blocking IL-8 by binding to the CXCR2 receptor, or trying to prevent activation and ingress of IL-17 cells, we haven't seen particular success. And this may be due to partly patient selection, that we really haven't focused specifically on patients with neutrophilic asthma in all cases, that we may not be getting enough inhibition of neutrophilia, that's a possibility. Or finally, and perhaps the most provocative, is that neutrophils, while they're present, while they correlate with a number of different endpoints at baseline in patients with asthma, they may not be the operative mechanism by which tissue damage is really being enacted. And we may have to think about other potential targets in the airway. So I'd like all of you who have attended, thanks for being online. Thanks for listening, and I'll be on the line for another 10 minutes to answer any potential questions.
Jonathan, thanks very much. On the azithromycin, going back even further historically, is the story of TAO, an older macrolide, which was found to have a steroid-sparing effect, but mostly just by inhibiting steroid metabolism. Does azithromycin, you might want to explain that to current people, and does azithromycin have any similar effect on steroid metabolism?
That's a great question, and I think a great point. The TAO story was a big story at National Jewish. Dick Farr, Sheldon Spector spent a lot of time on that, looking at TAO, and even Stan Zeffler more recently. And I suspect the reason it worked was partly because of metabolic effects on methylprednisolone and preventing degradation. But I think probably there were a number of effects that were probably very useful, and I think we sort of gave up on that before we understood the story fully. But certainly because of the effects on prolonging methylprednisolone and increasing levels in the bloodstream, it did become a drug that had issues in terms of making people more Cushingoid. It hasn't been seen with azithromycin to nearly that degree. And it looks like what we are really looking at If we look at the patients who are not on oral corticosteroids, particularly, we were seeing a pure effect on inflammation and on processes that are very central to both type 2 and non-type 2 asthma. Much less work has been done in the oral steroid dependent group, but my understanding is that it does not have the same effect on metabolism.
We have other questions out there. We've got 50 people.
Yeah, Mike Weiss here. Thanks for the wonderful talk. Also going back to the azithromycin sort of question, showing benefit, but then showing a certain percentage develop resistance over time. Was it powered enough to see if people initially had benefit, but those who developed resistance lost their benefit over the course of the year, or was it not looked at?
So the people that had, so let me parse it out this way. The people that had bacteria present did the best. So if you were colonized and you got azithromycin, you had the best outcomes. In all groups, there was a reduction in colonization by Moraxella and H-flu. But a certain percentage of patients did develop bacterial resistance to azithromycin. I'm not aware in the paper that they showed their outcomes with that group were any worse. If they had bacteria and they got rid of them, they ended up having good outcomes, the best of the group. But certainly a number of them, despite losing the number of bacteria or having a diminution in the number of bacteria, still did develop resistance at a bacterial level. So that if you had a bronchitis and it grew H-flu, azithromycin would not necessarily be the drug of choice. And I think that story is still being developed. I think it's a really great question. If you're going to use azithromycin in anybody, I think you want to follow sputum cultures and see what's going on and try to make sure that you get an effect in the beginning that you might potentially lose over time.
This is Vinod Doraiswamy, one of the community allergists. Thank you for a very important, wonderful talk. A question I had was, I think maybe you touched on bronchitis, bronchiectasis on this colonization, but maybe I might have missed that in terms of association. Is there some association that we looked at with, say, antibody deficiencies or specific antibody deficiencies in these people who have colonization?
I don't think they didn't work these people up in the AMAZES trial, which was the big trial for antibody deficiency. But I think your question is very much to the point that if we see people with recurrent bronchitis, as allergists, that's, I think, one of the first things that we would do is look at immunoglobulins and specific antibody deficiency. That may be partly due to the fact that I think the investigators in the AMAZES trial were largely pulmonologists. And the emphasis really in that group was not as much on looking at the underlying immunologic problems that these patients had. Great point, though, I think.
Jonathan, how important do you think it is that we do induce sputum? It seems to me we're using blood eosinophilia as a surrogate because it's technically difficult. Our friend and colleague Param Nair basically does induce sputum as readily as you do a CBC.
Mm-hmm.
So I guess how good is the correlation between induced sputum and blood eosinophilia?
Terrible. And the relationship between blood neutrophilia and sputum is even worse. So you're going to see some publications coming out over the next year, in which people who look like they had non-type 2 asthma at the tissue level actually had type 2 asthma. So I think it's really important that if you have somebody with EOs of 400, we're going to treat them, with inhaled steroids and then all the way to a potential biologic if they're severe enough. I think where sputum becomes critical, and I think we all need to start doing this, and I'm going to have to start too because I'm not doing it now. But after researching this talk, I'm going to definitely start doing it, is in people with non-type 2. So you consistently, and by that I mean, Monica Kraft says 3 occasions, But if you have a couple of data points, preferably with both pheno and bloody eosinophils, if they seem to be non-type 2, to get sputum. And if they have no sputum eosinophils, and they have a robust number of sputum neutrophils, even in the absence of obvious bronchitis, we really start to think about, is this bronchiectasis? Is this colonization? I think we have to chase those patients down with CTs if they're severe asthmatics and cultures, and maybe potentially, if you're Jim Good at National Jewish, potentially doing a bronchoscopy with BAL. So I think in the group of non-type 2, where we don't have a lot to offer them, particularly other than azithromycin and maybe in the near future tezepelumab, I think we need to chase these down a little bit better. Because if they do have bronchiectasis, you're going to really be, I think, as one of the attendees just pointed out very nicely, you're going to think about antibody deficiency, which is a potentially remediable problem and prevent the development of more bronchiectasis. You're going to think about mobilization using devices to vibrate the airway and expel mucus. So I think that in this non-type 2 group, we really have to start to try to at least develop a local inflammatory signature that might be useful in framing therapies.
Thank you. Somebody needs to mute themselves. Any remaining questions for what would be your first choice now if you felt you had a severe asthmatic who was type 2 low? It seems to me that the uptake of azithromycin, although the data look good, is rarely used in clinical practice.
It has had very poor uptake. And I think, the bulk of the research has come from Europe, and we've been much less interested in this. But I think probably based on the review of the evidence, it makes the most sense. And probably a lot more sense than trying to use a type 2 biologic like an anti-IL5 or one of those drugs. So I think this is very much an area that's rapidly evolving, and we need to think about it probably more than we have been over the past.
Well, probably a year from now, we'll have Tezi on the market, and so you'll have to come back and tell us how that's working.
Okay, that sounds a good deal.
All right. All right, any more questions before we sign off for the morning?
What's the word of the day?
Biologics.
There, thanks.
All right, everybody, have a good day. Take care.
Thanks, Len.
All right.
Bye-bye.
Thank you, Jonathan.